My name is Erin Wilt. This is SOAP Note 2. My patient's a 68-year-old Caucasian male. He is presenting today for an urgent care follow-up, which is in conjunction with the local crisis department for evaluation of a patient after they presented to crisis. So he was in the crisis center on 7/11 of 2026. He did not receive an inpatient stay. He was discharged home with direction to follow up today. His chief complaint is, I think the Ativan started this. He states that he has had worsening anxiety and depression over the last couple of weeks. He is the primary caregiver for his 38-year-old disabled son. He's been his caregiver on his own for the last 20 years since his divorce. He receives no in-home supports for him. He has no outside supports or groups that help him either. So he states over the weekend he had just had enough. His Ativan and his marijuana were not assisting him with his mood, so he did present a crisis for assistance. In discussing that, his medical marijuana is both indica and sativa strains. He states he's using that a lot daily. For his Ativan, he states he has 0.5 milligrams every morning and 0.25 every evening. He states that was given to him by his PCP for a colonoscopy prep in May of 2026. The colonoscopy has been completed, and his results, he reports, were fine. However, he's continued to take that prescription since then. PDMP shows 3 fills on the lorazepam, May, June, and July of 2026. Current medications, he's reporting none other than the 2 previously discussed. He's also reporting that he has no medical history, no surgical history, past psychiatric history, anxiety and depression. He has a previous inpatient psych hospitalization in April of 25. He then reported to this clinic for his post-visit from crisis and established services. He was discharged in November of 25 for non-adherence or non-compliance with his appointments. Denies suicide attempts, denies self-injurious behaviors, no current outpatient psych provider. He's reporting depressed mood, excessive worry, persistent anxiety, feeling overwhelmed. He's reporting difficulty relaxing. However, he has no additional sleep concerns, no changes in his appetite. He reports energy as decreased, mild impairment to his concentration, denies hypomania or mania symptoms, denies psychosis symptoms, no obsessions or compulsions, denies suicidal ideation or homicidal ideation, no weapons within the home. His risk assessment is low. Substance use assessment, he's denying any alcohol or illicit drugs. He does utilize the cannabis, which was previously discussed, and he is a 1-pack per day cigarette smoker for the last 50 years. Family medical history or psych history, he reports he has none to provide. However, he does confirm that there are no completed suicides within his family. Appearance, he appears well-groomed. He's wearing a t-shirt and jeans today with a flannel. His behavior is cooperative. He's visibly anxious, though. He is rubbing the legs and staring at the floor, as previously discussed. However, he does maintain eye contact when he's answering questions. Normal rate, rhythm, and volume to his speech. He states his mood is anxious and depressed. His affect is constricted and anxious, which is congruent with his mood. His thought process is linear logical. He is fixated on receiving a prescription today. No perceptual disturbances were observed during the visit. He's alert and oriented times 4. Attention and concentration are mildly impaired. Memory appears to be grossly intact. Insight is fair. He does recognize his triggers. Judgment is fair. He did present a crisis, and he is also here today. However, he's continued to take a prescription for Ativan, which he reports was a one-time use for his colo prep. There are no labs and diagnostics to review. PHQ-9 is a 16. GAD-7 is an 18. Diagnoses that I have for him: generalized anxiety disorder, F41-1, unspecified depressive disorder, F32A, and dependent relative needing care in the home, which is Z63-6. Interventions for him: non-farm. We recommend establishing services in an outpatient psychiatric healthcare practice, as this office is not accepting patients at this time. A referral was sent to his location of choice. Recommended psychotherapy. Again, referral was sent to the location of his choice. We did discuss seeing his PCP within 1 to 2 weeks to continue to follow him for the Ativan taper. We reviewed the potential for withdrawal symptoms from benzodiazepines and the risks associated with that. Also recommended that he see the PCP for follow-up of pharmacologic intervention that was initiated today, the sertraline of 25 milligrams daily. His pharmacy was concerned and a script was sent for that. However, this practice is not accepting patients, so his PCP will need to take over the sertraline for him. So we did discuss seeing his PCP for follow-up. The rationale for the medication: the APA and the VA do have clinical practice guidelines in place for major depressive disorder and generalized anxiety disorder. SSRIs are the first line of choice. So we did go ahead and offer that solution for him. We also discussed medical marijuana and its effect or potential effect with major depressive disorder and generalized anxiety disorder.